Bismillahirrahmanirrahim. Uh, Dear colleagues, it's a proud privilege for me and honor for me to be standing here and talking to you about these SGLT2 inhibitors. I have no conflict of interest about this topic. Uh, we all know that you know better than myself that diabetes affects about 400 million people around the world, and it is estimated that it caused about 1.3 million deaths in 2016. And cardio-renal metabolic syndrome, which involves type 2 diabetes, chronic kidney disease, and heart failure, is a very serious illness with very high morbidity and mortality. And these disorders can mutually coexist and can affect each other, and in fact can accelerate each other, thereby increasing mortality and impairing quality of life. A holistic treatment approach that can simultaneously address multiple disorders underpinning cardio-renal metabolic syndrome is of great importance. And a relatively new class of drugs, that is SGLT2I inhibitors, offer such an approach. We all know that an apple a day keeps the doctor away. I tell you why. Because these drugs are actually derived from fluorescein, which was extracted from apple bark back in 1835. And after 50 years, it was found to have glucoseuric properties. There has been always a need for new drugs after sulfonylureas, because these are drugs which cause a lot of hypoglycemia. And scientists have been in search for drugs which do not cause hypoglycemia and still control diabetes well. And in 1990s, pharmaceutical companies in Japan actually isolated these compounds. They made these compounds from fluorescein. And there have been 5 SGLT2 inhibitors which have been approved for use in 2012 to 2016. As you all know, there was a problem with the diabetic drug, the rosiglitazone, and there was a very strong suspicion that it increased the incidence of myocardial infarction in patients who used it. So FDA made a mandatory kind of a regulatory thing that all new anti-diabetic drugs have to be evaluated for cardiovascular outcomes. And this evaluation actually generated results which have been of great interest to cardiology as well as endocrinology communities, both. Now, first of all, I will try and explain how these drugs act and how these, they produce their actions. As we all know, these are basically the inhibitors of SGLT2, which is sodium glucose transpose co-inhibitor. It acts in the glomerulus and in the proximal tubule. We all know that sodium and glucose are freely filtered, and they are then actively reabsorbed into the tubules, from the tubules. So these drugs, they inhibit SGLT2 receptor. As a result, there is increased concentration of sodium and glucose inside the tubules, and there is decreased extracellular volume. Then as this fluid travels down to the distal tubule, it comes in close contact with the glomerulus. Then there is a macula densa. We all know that because of the increased tubular fluid in the distal tubule, there are certain changes which are that the tubular macula densa senses and inhibits the release of renin, which leads to ultimately vasoconstriction of the afferent arteriole and vasodilatation of the efferent arteriole. It is actually opposite the effect which is produced by diabetes. This is how it helps. Then these drugs also have direct effects on cardiomyocyte. That means they inhibit sodium and hydrogen exchange 1. We know that during this process of heart failure and cardiomyopathy, myocarditis, there is increased expression of sodium and calcium inside the cytosol, that is inside the cells. However, ATP and calcium are reduced in the mitochondria. This inhibition of NHE1 leads to increased availability of ATP and calcium inside the mitochondria and reduced calcium and sodium inside the cells. And this translates into ultimately increased utilization of ketone bodies by the myocardial cells, which reduces myocardial ischemia. There is increased ATP content in the myocardium, which ultimately leads to myocardium oxygen consumption, which is reduced. Then there is increased release of erythropoietin, increasing level of hemoglobin. Then mitochondrial level, increased level of calcium in the mitochondria leads to reduced oxidative stress. All this process leads to the decreased intravascular volume and decreased blood pressure. And there is a reduction in cardiac preload and as well as afterload. So this is called as a renal heart connection. And there is natriuresis, there is diuresis, there is decreased glomerular hypertension that leads to reduced left ventricular wall stress as well as increased oxygen delivery. Then we also, as I already explained, that the blood pressure goes down and the red cell mass increases. There is decrease in the plasma volume and there is decreased sympathetic activity. So we can say that natriuresis leads to decreased blood pressure volume and decreased plasma volume, which has hemodynamic effects. And glucose urea and uricose urea leads to reduced insulin resistance, decrease in body weight, increased utilization of ketone and increased ketones in the blood. And these are the metabolic effects. And all these effects lead to ultimately reduction in the risk of heart failure. So, if I summarize, the primary action of SGLT2 involves inhibition of the SGLT2 expressed on the proximal tubules, and these drugs express pleiotropic effects, which include reduction in body weight, blood pressure, intraglomerular pressure, reduction in hyperuricemia, inflammation, and oxidative stress. And there is inhibition of the sympathetic nervous system. And there is improvement of erythropoiesis, cardiac energy, metabolism, and vascular functions. So after knowing all these effects, ultimately, these drugs were put to trials. And there have been three main types of trials for the drugs. First, there have been, as I told you, that all the new anti-diabetic drugs have to be tested for cardiovascular outcomes. Then there are cardiovascular outcome trials. Then when we had evidence that they also, improve heart failure, there were treatment. There were specific trials on heart failure and then on kidney and kidney disease trials. So I'll talk about them briefly, all of these groups. First of all, cardiac outcome trials. Empagliflozin cardiovascular outcome trial, the EMPA-REG outcome trial was the first trial of this type, which was published in New England Journal of Medicine in 2015. And these were the patients who had type 2 diabetes and they were given this drug. And the dose was 10 milligram or 25 milligram. There were about 7,000 patients which were included in the group, the placebo and the other group. With this drug, ultimately we found that those patients with for cardiovascular risk events, the number of events were reduced, the number of hospitalizations were also reduced. Next trial, which was published again in 2017, was the Canvas program collaborative group trial. Actually, these are two trials. And again, in this trial, gliflozin was tested. And in this patient, there are about 10,000 patients who were tried. And the mean age of participants about 63 years. And in these two trials, again, what was found was that cardiovascular outcome were better as compared with placebo. The number of hospital admissions, non-fatal myocardial infarction, strokes, and unstable angina was reduced. The next trial was again on canagliflozin, and in this they also included a study of renal outcomes in type 2 patients and diabetes. And this trial was actually stopped early because demonstrable there were a lot of efficacy, good results which were demonstrated, and it was unethical to deny the patients who were on placebo. So this trial stopped. Again showed a lot of benefit, as I already told you. Then the first trial on dapagliflozin was DECLARE TIMI 58 trial. This was published again in New England Journal of Medicine. Most of these trials have been published in this journal in 2018. And this patient actually evaluated a very large number of patients. Almost 17,000 patients were evaluated included in this trial. And they were followed up for 4.2 years. And again, in this group of patients, dapagliflozin did not result in a higher or low rate of MACE than placebo, but did result in a low rate of cardiovascular death and hospitalizations. Then the next trial, a lot of trials have been published of these trials. Next trial which was published was on articulately. This is known as Vertis CV investigations trial. Again, this was a multi-center, double-blind, randomized trial which included about 8,000 patients. And in these patients with the atherosclerotic cardiovascular disease, It was non-inferior to placebo with again a reduction in major cardiovascular events. Then this drug, sotagliflozin, was tried in patients with diabetes and kidney disease. This drug is different from other SGLT2 inhibitors because this is inhibitor of not only SGLT2 but also of SGLT1, which is found in the intestine. This drug was actually developed for patients with type 1 diabetes because it was thought that inhibiting enzyme in the intestine would lead to less episodes of hypoglycemia and type 1 diabetes. Again, 19,000 patients were screened and 10,000 were enrolled, more than 10,000 were enrolled in this drug. And in this trial, the patients with albuminuria or without albumin, they were all included, even those who had chronic kidney disease. Again, this trial also showed a reduction in the events of cardiovascular death and other events. But the problem with this was that there was a high incidence of diabetic ketoacidosis. Almost the group who had this drug has 5 times increased incidence of diabetic ketoacidosis. So this is a point which is to be noted. Then there have been meta-analyses which have been published, and from this data, you can see this chart. All of these trials, we have over almost 57,000 patients data now, and like AMPA-REG outcome, Canvas program, Credence, Declare TME, 58, Vertis CV, and SCORE trial. And all of these trials have led to reduction in cardiovascular death and risk for admission in hospitalizations. All these we can conclude that SGLT2 inhibition improves cardiovascular outcomes, including cardiovascular death, non-fatal myocardial infarction, stroke, and unstable angina. And outcomes, that is low risk of hospitalizations and death, are also improved in patients with heart failure and over a wide range of ejection fractions, regardless of whether these patients are diabetic, type 2 diabetic or not. In real-world studies comparing SGLT2 inhibitors and other glucose-lowering drugs suggest that cardio-renal benefit seems to be independent from the glucose-lowering effect. Now, there was one trial which actually compared these two commonly used drugs, this DAPA and as well as AMPA. And it was interesting to note that DAPA had shown actually better results than AMPA in Asian patients. Again, there was another review published which stated that these drugs actually, as compared with the other population, Asian patients actually benefit more from these drugs. So we have to note this because we are Asian and these drugs are of great benefit. Now we come to the heart failure trials. We know that there are 6 million adults in the United States have heart failure, and accounting for almost 800,000 admissions every year. And in industrializations, approximately half of patients with heart failure have a preserved ejection fraction. I'll be explaining that in a moment. And it has to be noted that the mortality with this type of heart failure is again quite high, between 20 to 30% per year. Now, this is a crowded slide, but try and explain this. On the left side, this is a traditional sign of heart failure statement that we used to have, high output failure and a low cardiac output failure. Then we used to, so this is all we studied in our school, 5th year medicine, right side heart failure and left side heart failure. But I think in 1990s, we started noticing that there were patients who would come to us with pulmonary edema, but their LV function used to be normal. At the same time, patients were admitted with acute coronary syndrome, which at that time we used to call as acute coronary insufficiency or subendocardial MI. Many of these patients actually had normal EF, but still they would go into heart failure. It was not well understood then, but now we know that this is, heart failure with preserved ejection fraction. You can see that now the left side heart failure is divided into two groups. One is the one with the low ejection fraction. The other one is with the preserved ejection fraction. And then now it has been, kind of heart failure has been further divided or studied or, divided into patients who have just risk of heart failure. Then there are patients who have actually a disease of the heart, but they are compensated that they do not have heart failure or they have been treated well. Like a patient who has hypertension or has a cardiovascular disease, has a diabetic obesity, exposure to cardiovascular family, if cardiomyopathy, that would be stage A heart failure. Then with patient who has had a structural heart disease like cardiomyopathy, abnormal cardiac function after an acute myocardial infarction, it would be kind of stage B or pre-heart failure. Then there is classic heart failure, patient who have damaged heart, and they are either into a persistent heart failure or they are into go into remission. And then the final stage is advanced heart failure, always in heart failure, class 4 NIHA, and who actually need a lot of treatment, including cardiac transplantation. So this is the kind of group of classification of heart failure today. Heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and then there is a third group, which is EF more than 40%. This is called as heart failure with mildly reduced ejection fraction. So we go on. So just to briefly explain the pathophysiology, we all know that after heart is damaged, there are processes which improve the cardiac function, that is ventricular dilatation and infarct expansion. This ventricular dilatation initially is good for the heart, it improves cardiac output, that results from the activation of the renin-angiotensin system as well as sympathetic system, but good for the short time, but long term the fluid retention ultimately leads to pulmonary edema and it aggravates the heart failure. And those drugs which inhibit this system have been of great help in the heart failure. Now I come to the trials of SGLT2 inhibitors in heart failure. Now the first heart failure trial with reduced ejection fraction with dapagliflozin was the DAPA heart failure trial. And in these patients, these are basically patients with type 2 diabetes who were given these drugs who had risk of heart failure. And all of these patients had a reduced ejection fraction, and the risk of worsening of heart failure was reduced as compared with the placebo. So this was again a successful trial. It had a follow-up about almost 1.5 years, that's 18 months. Next trial was again with heart failure with reduced ejection fraction. That was Emperor reduced trial. That the drug was empagliflozin. And this was again a double-blind trial. Almost 3,000 patients were included, and patients, they were recommended to be treated along with the standard therapy, and they ultimately had a lower risk of cardiovascular death or hospitalization for heart failure than the placebo group, regardless of the presence or absence of diabetes. So again, this showed that this drug could have an independent effect on heart failure than from the diabetes. Then this is the heart failure. Then after encouraging results with these two trials, the scientists, they tried this drug, patient who had suffered heart failure, and then after the heart failure, this drug was started. So this was trial, but the drug was the sotagliflozin, and this was started on the first day of discharge after hospital after having an episode of heart failure. Again, the results were positive, and these patients had much better outcomes as compared with the patient who did not have this drug. Then next, after having encouraged results, these drugs were tried in patients who had preserved ejection fraction. Like we have very good treatment therapy, at least what we think, that for the patients who have reduced ejection fraction, like we have diuretics, ARNI, beta blockers, all have a lot of aldactone, a lot of established trials, but we do not really have good pakka treatment. We do not have for the heart failure with preserved ejection fraction. And these drugs were tried, and again they were encouraging results. And this is now kind of a standard treatment for heart failure. And another trial was again Emperor Preserve trial. This was published in Circulation. Then we had a trial on dapagliflozin in heart failure with mildly reduced or preserved ejection fraction. Again, there was follow-up of 2.3 years, and the dapagliflozin reduced the combined risk of worsening of heart failure or cardiovascular death among patients with heart failure, and a mildly reduced or preserved ejection. So these drugs have produced results in the full spectrum of heart failure, starting from reduced ejection fraction to mildly reduced ejection fraction to preserved ejection fraction. Now this is basically again an analysis of all these 4 trials. All of these trials have shown benefit patients with heart failure. These are the cardio outcomes with patients with type 2 diabetes. Again, the results were very positive. Now, after having tried these drugs in chronic heart failure and in preserved ejection fraction, another trial was conducted, which is impulse trial. And in this trial, this drug was employed in patients suffering from acute heart failure, the patients suffering with acute, LVF. And again, this drug was of benefit, and benefit was obvious. So this drug proved the benefit of these drugs in patients with acute heart failure. So I will of course, I have to follow the directions. So I will just run through. These are the standard treatment. Now we use SGLT2 for these drugs. This is conventional treatment, and this is now you can see the step 1. We have beta blockers and SGLT2 drugs for these patients. Now, recently, after having this encouraging data, most of the cardiac authorities and societies have updated their recommendations for treatment of heart failure. The latest was a focused update from the European Cardiac Society, released a couple of months back in August. And just to explain this green means that there is a very strongly indicated. Orange and red means, orange means maybe benefits, red is do not use it. And this, dark green means this evidence is strong. B, less green means evidence is okay. And C means just an expert opinion. So for the patient with preserved as well as for mildly reduced ejection fraction, this is class 1 and level of evidence is A. So this is very strong double-blind, multiple-blind data as well as very strong evidence. This is just a repetition now. All of the spectrum of heart failure has got the recommendation for these drugs. And this is the recommendation by American Heart Association. And there were 10 take-home messages. The first 3 messages, they include recommendation about SGLT2 inhibitors for heart failure, preserved ejection fraction with mildly reduced and for reduced ejection fraction. This has just been recommendations. I've already said that. Now move on to the SGLT2 and the kidney disease. We know that diabetic kidney disease occurs in 40% of patients with type 2 diabetes. And there have been multiple trials. I have already referred to these trials: EMPA-REG, Emperor, Canvas, CREDUS. All of these trials actually have shown benefits in patients with chronic kidney disease. Now, once we had evidence that these outcome trials have shown benefit in the kidney disease, there were specific trials on kidney disease. And this was a trial which is called as DAPA-CKD trial. This was conducted on patients with chronic kidney disease. And in the first trial, the creatinine clearance was used to be more than 45. In this trial, the patients having as low as 25 ml per minute were included. The range was 25 to 75. And again, it showed benefit. And then I'll move on. Then there's a trial on kidney disease with empagliflozin called as EMPA Kidney Collaboration Group trial. Again, this trial showed benefit in patients with chronic kidney disease. And again, in these patients, their patients have albuminuria, wide range of albuminuria, as well as eGFR of 20 to 40 ml per minute. And again, this EMPA kidney trial were terminated prematurely because of benefit shown or efficacy shown by the trial. At present, the American Diabetes Association recommends that all patients with type 2 diabetes and stage 3 kidney disease, the use of SGLT2 inhibitors is strongly recommended, owing to their effects on the slowing of chronic kidney disease, progression, and risk of heart failure. This recommendation is also based on the finding that renoprotective effects of SGLT2I were not dependent on eGFR, despite an attenuated glucose lowering effect in these patients with eGFR. So they have all been approved for the chronic kidney disease by FDA also. Now, kidney disease conclusion. SGLT2 inhibitors are responsible for major paradigm shifts in the care of patients with or at high risk for heart failure, progression of kidney disease, or both. In addition to having glucose-uric and natriuretic properties, these agents also reduce the risk of end-stage kidney disease in patients of type 2 diabetes and chronic kidney disease. Now, what are the problems with these drugs? What are the side effects? What are the precautions? In all of these trials, there has been a consistent increase of diabetic ketoacidosis as well as an increased risk of volume depletion in these patients. So this is part to be noted. This was especially true for the sotagliflozin trial. Overall trials have shown superiority but not inferiority in reducing the risk of acute kidney injury, because these drugs, they do produce volume depletion, and at times they do cause acute kidney injury. But overall, the data favors their use. And then what we need to make these patients aware of symptoms of diabetic ketosis. These mostly are lightheadedness, fatigue, abdominal pain, nausea, and vomiting. Then these, because of the glycosuria, these make the patients prone to fungal genital infections, urinary tract infections, perineal infections, even Fournier's gangrene. And in the Canvas trial, there was some increased risk of fractures as well as amputations of metatarsal bones. Now, just to conclude, SGLT2 inhibitors are a new class of orally active drugs in the management of type 2 diabetes that promote glucose excretion in the kidney. SGLT2 inhibitors not only improve fasting glucose, but HbA1c, but are able to induce blood pressure reduction and weight loss, improvement of cardiovascular outcomes, and improvement in chronic kidney disease. The nephroprotective effects of SGLT2 have been demonstrated in several major interventional trials. The effect induced by SGLT2 is on renal function are likely independent of glucose levels, and thus these medications can also use in patients with chronic kidney disease without diabetes mellitus. Same goes for the heart failure also. And SGLT2 inhibitors have become an essential therapeutic option to prevent the onset, slow the progression, and improve the prognosis of cardio-renal metabolic syndrome. Thank you very much. This is the last slide. This actually shows the scientific advances and reduction in cardiovascular mortality. It starts from the 1960s. Now, like the mortality in USA in 1900 was low. It jumped maximum to 1950s. From there, we had a Framingham heart study and data, risk factors, and ultimately interventions were made. Just to see this cardiac care unit developed, risk factors defined, first bypass. Then we had a national blood pressure control program. Then we had a cornea angioplasty in 1979. We had the statins in 1976, and this streptokinase trials, TIMIs and IGC trials. Then primary PCI, then hypertension control trial, lipid lowering, then sequencing. And this graph actually shows the reduction mortality till 2012. Since 2012, there are two major advancements. One is the paradigm heart failure, this ARNI drug, and second is the SGLT2 drugs. These will pull this graph down here. Thank you very much. Thank you very much for the patient listening.